Sure. So I'm a urologist in New York City.
Mhm.
I specialize in men's health with a focus on sexual wellness, erectile dysfunction, low testosterone.
Mhm.
We do treat some women, but mainly the focus is on men and benign diseases of the prostate and sexual health.
Okay. How did you get into that specialty?
Well, that's a long story, but basically, it was urology is a combination of medicine and surgery.
Mhm.
So it so I liked it. You have a long-standing relationship with patients, and I love sex. Love talking about sex. I love everything about sex. So it was a perfect fit.
Sounds like you found your right place to be. Good. So many of the men I'm sure that you work with and who I work with are talking about their sexual virility and changes in it as they get older. And you recently wrote a blog for Modern Intimacy about low testosterone being one of the culprits of changes in
Hmm.
sexual virility. So can you tell us a little bit about testosterone and how it functions in the body?
Yeah, absolutely. But I just want to. This is a conversation I have almost every day with men. The
Mhm.
changes that happen with male sexual function or virility, as you said, with aging. So the first thing that men notice is the latency period increases. So when you're a young man, a teenager in your 20s, you could have sex 2 or 3 times a night, no problem.
Mhm.
So that's the first thing they notice, the latency. And maybe they can only do it once a day or, maybe 2 or 3 times a week. So that's number one. Two, the erections may be not as rigid, not as reliable. So confidence in your sexual function goes down. Orgasms may be a little less intense. Ejaculate volume goes down. So one of the main causes, there's a lot of causes. There's vascular causes in older men, men with comorbidities like high blood pressure, diabetes, have a whole other set of problems causing it. But low testosterone is very common. So men's testosterone levels decrease as they get older. So
Mhm.
men's testosterone levels peak in their 20s. They sort of plateau, and in the late 30s, 40s, it starts to decrease.
Mhm.
Things that hasten the decrease in testosterone: diabetes, men who are HIV positive, opioid use. These people, opioid users, 90% have low testosterone.
Mhm.
Obesity. So obesity is exacerbated by low T, but it also causes low T. So basically so the most important thing is a good healthy lifestyle, good diet, exercise, weight training. These are all things people can do to improve the natural decline.
Okay. So the natural decline. So what are some of the kind of pharmacological options that are available if someone is struggling to halt the decline of testosterone or they want to see a quicker return to their sort of pre-morbid level of functioning?
So, well, one thing we could do is replace testosterone. So give
Okay.
man testosterone. Um, so there's different ways to do that. There was just a pill. The first pill was approved, a testosterone supplement or replacement. There's gels, there's pellets, there's injections. So there's different ways to give people testosterone. The thing you have to be careful about as a prescriber is when you give somebody testosterone, what you're doing is you're suppressing their body's own production.
Mm.
So there's this very intricate feedback mechanism between the pituitary gland and the testicles. And when you give someone testosterone, you're telling the pituitary gland, we're fine. We have a lot of testosterone. The pituitary gland stops stimulating the testicles.
Mm.
So sperm count can go down, testicles can shrink. And if people are on long-term testosterone replacement at very high levels, like bodybuilders
Mhm.
who are abusing testosterone, they lose their ability to produce testosterone, and it may be irreversible.
Really? Wow.
Yeah.
Okay. That's a pretty significant risk.
Yeah. So if somebody's really low and not making it, or if it's an older man where you're not concerned about things like fertility, then we give testosterone. Or if it's something called primary testosterone, so if the testicles really aren't functioning, then you have no alternative. Many people, it's a pituitary problem. So the pituitary gland is not stimulating the testicle appropriately. So in those men, we try to stimulate the pituitary gland to stimulate the testicles. So rather than suppress testicular function, we're enhancing testicular function, preserving testicular volume, preserving sperm and fertility. So those medicines are Clomid, which is historically a drug to treat women with infertility, and HCG, which stimulates the pituitary gland directly.
Okay. So what are some of the things that men will notice not related to their sexual functioning to signify a drop in their testosterone? What else can they be aware of?
Yeah, I almost can diagnose low testosterone on hello. You know, the patients usually just look a little less virile. They may have a big belly. They have generally less energy, fatigue. That's the main thing. Sometimes focus, mental acuity and focus.
Okay.
So I have some patients who, remember one patient, we would put pellets in every 3 or 4 months. And he came in and he'd come in and say, my wife told me to get in to see you that my testosterone level must be low. So I, of course, assumed he wasn't performing sexually. I said, you know, you having problems in the bedroom? He said, no, it has nothing to do with that. I stopped doing work around the house and I don't take out the garbage and I just sit around. So that's what annoys me. What?
Yeah, that probably impacts their bedroom life too.
Right.
Yeah. Okay, so that's interesting. I didn't realize that there could be such a sharp drop in sort of cognitive functioning or focus.
Yeah, absolutely.
Interesting. Okay. What are some of the other medical conditions that can either complicate or exacerbate low T?
Well, the most common is type 2 diabetes. So type 2 diabetes is extremely common in the United States. It's associated with obesity. Obesity is, so what happens with obesity? Well, it's it depresses the pituitary function, as does diabetes, but also testosterone gets broken down into estrogen in fat. So more fat, you have less testosterone and more estrogen. So that's another pharmacologic tool that we have. Medicines, they're called aromatase inhibitors. Most commonly is anastrozole. And what that does is it blocks the conversion of testosterone to estradiol. So sometimes we have really obese men, they have profoundly low testosterone, and it's very difficult to get their levels up to where we want them to be. So in those people, we'll add anastrozole to block that breakdown of the testosterone.
Okay. That's it. So not only then is there an increase of its production, but the medication helps prevent it from being broken down as quickly.
Integrated, yeah.
Yeah. Oh, interesting. Okay. So I wonder if testosterone plays a role in some of the other kind of sexual dysfunction issues that some men will report, such as early ejaculation or delayed ejaculation.
Delayed ejaculation more commonly. So if somebody is having problems reaching climax, the first thing I'll do, check his testosterone. And that could, so orgasmic dysfunction can be influenced by testosterone, ejaculate volume, intensity of orgasm. Premature ejaculation, less so.
Okay.
So, which is a much more common problem in our practice, and I'm sure in your practice.
Yes. Well, yes. So what are some of the indicators that someone maybe has too much testosterone, whether naturally or because they're supplementing?
Well, I can't think of anybody who had too much testosterone naturally.
Okay.
So there are men who have higher testosterone. So it's interesting. So people use the term menopause, andropause.
Mm-hmm.
Those are terrible terms because it has not analogous to menopause in women. So women at a certain age stop producing hormones, and it's a fairly dramatic drop. Men, it's a very gradual decline that occurs over time with aging and certain comorbidities. So so I really don't like those terms. But so what was the question again? I got off on a tangent.
I appreciate you bringing that up.
A little low, so I may need a boost.
Okay. Your acuity's not as sharp.
I remember. High.
Yeah.
Yes. So people who are high testosterone guys are going to be, more virile, you may have increased muscle mass, more muscle mass than someone with low testosterone. But really, unless there's a very rare form of tumor that forms testosterone, like an adrenal tumor or pituitary tumor or something, that's not common. Signs that somebody's abusing testosterone are they may have acne. That's a sign. They may have very small testicles. So people who have very, very high testosterone, as I said, you're suppressing their pituitary function and the testicles will shrink. I see several times a year a man who comes to me for infertility, either abused testosterone or been inappropriately prescribed testosterone without the doctor asking him if he's interested in having children. So sometimes we could recycle them by putting them on Clomid, which stimulates the pituitary gland to get them back on track. Sometimes, depending on how high the levels were and how long they were on it, it can be irreversible.
Okay, so any other takeaways that you feel like men or partners of men ought to think about or know about when it comes to low testosterone?
Yeah, so if you have sexual dysfunction, particularly low libido, you should have your testosterone checked. If you are obese, if you're having trouble maintaining muscle mass, if you're moody, depressed. So the signs and symptoms of depression and low testosterone are almost identical. So many men who are on SSRIs for depression, nobody checked their testosterone, and vice versa. So it's very common. It's easily treated. I just should add, there are several articles in the past 5 to 10 years suggesting that testosterone may be harmful, that it may increase major coronary events. And there is a small subset of people who are at increased risk of hypertension, possibly heart attack or stroke with testosterone. So patients should be of relatively good health. They should be prescribed by a doctor who's educated in treating low testosterone. You have to follow the prostate, the PSA level, red blood cell counts, because your blood can get a little thicker on testosterone. So it's good for anemia, but it can go the other way. Follow the blood pressure. So I think it's a good, safe treatment if used appropriately.
What would you say are some of the biggest impediments that you see working with men for them to get treatment around this issue?
Well, men are notoriously non-compliant. So if they don't see an immediate effect, they'll stop taking it. So the compliance with, when we use the gels, which we don't use very much anymore, was about 20 or 25% at 3 months. Why? Because the gels were messy, sticky, people didn't like it, and they didn't see the benefit because you didn't get great levels. So doctors wouldn't check the levels. They just give them the prescription and not titrate. So you want to make sure you get people in the proper range or mid-normal range. Follow them. You have to manage expectations. And our compliance rate with testosterone is like 90% because patients see the difference.
Okay, good.
Everybody wants to be younger, right? Everybody wants to be more virile. Everyone wants to have more muscles, be sharper. So it's not the fountain of youth, but it really makes a difference.
Yeah. Well, thank you. I really appreciate your medical perspective on this topic. And I know certainly a lot of the men that I work with and their partners feel pretty flummoxed and pretty disheartened when their testosterone starts to drop. And oftentimes they don't really know where to start, or they feel some shame or fear around what it means to need a testosterone evaluation or to get treatment. And so I wonder if you can speak to that part of the male experience.
Well, men are very tied into their sexual function. So their ego is very, very much attached to their sexual function, their masculinity. And so when that starts to diminish, the men could get depressed, they could withdraw, they may withdraw from their partner, they may avoid sex and any form of intimacy. In my practice, it's in Manhattan. I think we have pretty sophisticated type A personalities. So these guys, they want to get treated. If they don't have an erection one night for the first time, they're in my office the next day saying, "Hey, you got to help me. What's going on?" So I think, Viagra has been available for about over 15 years. So I think there was a real sea change in the way men viewed aging and changes with aging with Viagra, and over the years that it's become less shame involved, more acceptance. We used to talk about impotence, being impotent. That's sort of a pejorative, negative term. Now we say sexual, erectile dysfunction. Well, everybody at one time or another has erectile dysfunction. It's a broader, you see your advertisements for these drugs on the radio. So people are bypassing doctors, which I don't think is a good thing, because sexual dysfunction, erectile dysfunction, very often is a leading indicator of vascular diseases, of diabetes, of hypertension. So it's a symptom that can represent other problems. So it's an opportunity for people to be checked and to be evaluated.
Yeah, great. Thank you.